Good evening, everyone. Today's topic of this session is scoring systems in anesthesia. So, as we know, there are various scoring systems. Some of them we use routinely in the operation theater. Some of them we use after giving spinal anesthesia to check the level of spinal anesthesia. While many of the scoring system are ICU related and pain related. So in a nutshell, we will try to cover the major scoring systems that are used in our day-to-day practice. So whenever a patient is posted for any procedure, the first step the anesthesiologist has to encounter is the pre-anesthesia evaluation or the pre-operative checkup. Now, various parameters have to be checked so as to assess the difficulty level in providing anesthesia care and preparing a proper anesthesia plan. So, all of these scoring system help us in defining the grade of the patient and to subsequently formulate a proper anesthesia plan. So this is the basic American Society of Anesthesiology grading system of the patient depending upon the various comorbidities the patient is suffering from. So there are 6 divisions in this ASA classification. The first classification is the normal healthy patient. So a patient having no other comorbidities, no addictions, healthy patient with no smoking, no or very minimal drinking. ASA2, where most of our patients that we give anesthesia lie are the patients with mild systemic disease, which includes smokers, occasional smokers, more than minimal drinking, all pregnant patients, all obese patients above the BMI of 30, well-controlled diabetes and hypertension, and mild lung disease, not incapacitating their routine functioning of daily life. So well-controlled chronic diseases all come under ASA2 along with pregnant and obese patients. Coming to slightly higher grade of difficulty level, which come under ASA3, which are patients with severe systemic diseases, though not incapacitating, still that well controlled, but again, it is not that incapacitating as well. So again, here poorly controlled diabetes, hypertension, any distant history of myocardial infarction, cerebrovascular accident, any TIA history, any history of cardiac stent placement, COPD, ESRD, patients on dialysis, patients with active hepatitis, patients with implanted pacemaker, or old age fragile patients with an ejection fraction below 40%, and patients having some congenital metabolic abnormalities. All these subset of patients come under the ASA grade 3. Coming on to ASA grade 4, here those patients who are having severe systemic diseases, which again is a constant threat to life, like a very recent history of MI, CVA, TIA, or any cardiac abnormality, ongoing ischemia or valve dysfunction, and ejection fraction way low below 25%. So all these are very high risk patients coming under the class of ASA 4. Then coming to ASA 5, those are moribund patients who are not expected to survive without the said procedure. For example, a ruptured abdominal or thoracic aneurysm, wherein you have to open up the patient or do some intervention, otherwise the patient will lose his or her life. Again, patients with intracranial bleed with a midline shift, a big mass effect, ischemia bowel in the face of significant existing cardiac pathology. So all these patients who have to go under the knife, otherwise they will not survive. They come under the ASA grade 5 section. Then there is a special subset of patients who have already been declared brain dead and whose organs are being removed for transplantation. So they come under ASA grade 6. So apart from
Class
all
ಇದೆ.
classification, if the patient is being assessed for an emergency procedure, then we have to add an suffix E in front of these respective classes to denote the emergency status of the ASA classification. So an ASA grade 5E will suggest that the aneurysm has been ruptured and the patient has to undergo some or the other procedure to plug the leak. So when we add the suffix C, it indicates the emergency nature of the surgery. So when we have an ASA picture in our mind, we can accordingly classify our anesthesia management plan accordingly. So just to illustrate a few examples, a 19-year-old college student was scheduled to undergo an emergency surgery post motor vehicle collision or a traumatic brain injury. He had a BMI of less than 30, and he is giving history of recreational substance abuse, sometimes alcohol, and well-controlled gastroesophageal reflux disease. Now, this patient, you can classify it as ASA class 2 for being in the range of overweight BMI with recreational substance abuse but well-controlled reflux. And as the nature of the surgery is emergency, we add the suffix E to ASA class 2. Now, we should remember that the patient's full stomach will not impact the ASA classification, but it will obviously increase the overall anesthesia risk. So, fasting status is not being considered in this classification, but your plan of intubation or the need to use rapid sequence intubation will depend upon whether the patient is fasting or not. Another example is a 55-year-old man scheduled for an emergency repair of a large abdominal aorta after being thrown from a horse. He additionally has sustained some other fractures like 8 rib fractures and a pelvic fracture post-fall. He also had an history of a circulatory arrest in the emergency department from a massive hemorrhage and had required 2 rounds of cardiopulmonary resuscitation before the spontaneous return of circulation. Currently, he is undergoing massive blood transfusion according to massive transfusion protocol in view of ongoing blood loss from the laceration and the hidden blood loss from the pelvic fracture. Now, this patient has to be classified under ASA class 5, also emergency, as he is not expected to survive beyond the next 24 hours without surgery. So, any patient undergoing any surgery in emergency will be graded as ASA class 5. If the surgery is not done, then the patient will not survive. So when we are assessing any patient, we have to assess the cardiorespiratory system of the patient. So one of the classifications to assess the cardiorespiratory status of the patient based on the history taking itself, one of the classic examples here is the New York Heart Association classification, which provides a simple way of classifying the extent of heart failure. Now, this divides the patients into one of the 4 categories based on the limitations during their physical activity and the symptoms which are in regards to normal breathing and varying degrees in shortness of breath or angina pain. So basically we take proper history and divide the patient into 4 classes. The first one is patients having no symptoms and limitations in ordinary physical activity. The second class is slight limitation of physical activity and ordinary physical activity resulting in mild symptoms such as fatigue, shortness of breath, and angina. The third group of patients, they present with marked limitation of physical activity and less than ordinary physical activity leading to those symptoms. And the fourth group of patients, those are with severe limitations of physical activity and they experience symptoms like angina, breathlessness, even at rest. So these are the worst kind of patients will require thorough optimization and high risk of grading and proper explanation to the relatives that the need of post-op ventilation and ionotropic supports will be more in these class 4 patients who experience symptoms even at rest. Whenever any patient is posted for a surgery, there are some surgical risk factors. So the American College of Surgeons have formulated an NSQIP program, namely the National Surgical Quality Improvement Program. Now, it is a free calculator which is available online, and the patients themselves or their relatives can just log into the website and put their data regarding their symptoms, their current age, height, weight,